patients are to be can be treated with a brace, and more than 40% anterior compression and more than 20-degree angulation, posterior instrumentation and fusion is to be done. In burst fractures with neurological deficit, less than 30% canal compromise, posterior instrumentation fusion is to be done. More than 50% canal compromise, anterior decompression with instrumentation and fusion. Whereas when in a burst fracture without neurological deficit, less than 40% canal compromise, patient can be treated with a brace, but more than 40% canal compromise, more than 20-degree kyphosis, more than 50% of loss of body weight, posterior instrumentation and fusion to be done. In a case of flexion distraction injury, if there is a injury through the bone, patient can be treated with a brace, whereas if it is through the ligaments or disc space, posterior compressive instrumentation is required. In a fracture dislocation, posterior reduction and instrumentation and fusion is done as shown in the radiographs. In minor injuries like spinous process and transverse process fractures, symptomatic treatment or just orthosis is to be given. Post-operative protocol, whether patient has to be mobilized early or late, depends on the choice of a surgeon. However, it is a controversial issue, and thank you for your kind attention.
Thank you, Dr. Shyam.
Yes.
Now, is there any question to Dr. Arvind Kulkarni, Dr. Harswar Hegde, Dr. Ram Chadda, and Dr. Shyam Sundar? Dr. Ram Chadda will come here and
combined question to all the three speakers are,
yes.
most of the patients, they landed with complete paraplegia with all the loss of sensations, and there is a compression, and the patient, they want to know whether they would improve by motor sensations or not. Is there any signs clinically or maybe MRI signs we can tell the patient will improve or not? Because most of the time the cord is not transected, and still there is a complete paresthesia, complete motor paralysis, and patient want to know prognosis before surgery. Can there some signs to that?
At which level is the injury?
The dorsal lumbar. T12L1 is the most common cause.
If the perineal sensation, that is S4 and S5, if they are intact,
Lost. That's clear.
Yeah.
Below umbilicus, everything is lost.
Yeah, if that is lost, there is likely to be no poor prognosis. Surgery is to be done only for early mobilization on a wheelchair.
The patient, poor patient, they don't want. They
Yeah.
can wait for 3 months. They can sit and they can. But just for sitting, that's all.
Yeah, early mobilization.
My question is not. My question is there are few cases recorded. They have surgeons have operated and patients have improved. What are those cases? Can we take out those cases?
Dr. Ram will reply.
So the few patients who recover, there are very few who have had a total shutdown preoperatively who recover. Very few. They would be anecdotal, and I would rather put my foot forward and say that those people who recovered and who were reported as preoperatively totally shut down were probably incomplete, and there was some recovery which occurred. But there are very few which are totally shut down.
Find out those cases?
Sir, that's exactly. We are talking of what you are looking at as a physiological cord transaction, but not a classical anatomical transaction, right? So physiological transaction is the picture that you are trying to paint, where everything below the umbilicus is grade 0 motor plus sensory. Well, in those instances, I would really sort of take it with a pinch of salt if somebody says that patient recovered by more than 1 grade Frankel, which also I take with a pinch of salt, because that 1 grade Frankel is not going to make any functional improvement to the patient. But if there is a patient who came with total sort of paraplegia and recovered, it is because that patient was probably in that short period of spinal shock during which we surgically intervened. He was probably destined to recover despite our surgery. Our surgery actually did not do much. So we as surgeons can only change the anatomy. We cannot change the physiology. We can do whatever we can for anatomy, making an unstable thing more stable, making a painful neurological compression, supposedly remove the neurological compression and hope that it becomes less painful. That is all that we can do as surgeons.
You mean if you don't remove the compression,
Yes.
that even then the motor function would same come?
Can recover? Yes, it can. That is what the study has also said, which was initially made in other parts of the world and now has come from our own country, that there is no correlation between a clinical and a radiological finding. You will see 70% canal compromise, patients are walking in, and you will see a completely open canal and the patient is totally shut down. So there is no,
That is vascular, that shows.
no, you may call it vascular, it may be just a temporary insult and a total physiological transaction. But as far as I am concerned, yes, incomplete progressive neurology under your eyes, patient came with a grade 4 to 5 power, deteriorated to grade 1 to 2, yes, please intervene, and those patients do tend to recover. Otherwise, no. That's the way I don't know. I have, what would you like to say?
Actually, I have never seen such patients. People
No,
talk
I
about
have.
this-
Those
No.
with incomplete deficits recovery.
No. Complete injury.
Complete deficits,
Complete
no.
surgeries, I see
No.
at
We
least.
wait for the spinal shock to be over and then intervene.
So
or-
we don't know whether it is spinal shock at that time, sir. To be very frank.
So most of us operate basically
How
to
long to
stabilize the segment so that the patient can be ambulated.
That's right. And also you want to prevent secondary neuronal damage in case the patient is one of the lucky ones who escapes out of that. But if there is, like you said, clear-cut evidence of paraplegia, these patients don't recover. Or the earlier examination that was done was probably faulty, erroneous.
So how long to wait is a question which you asked, I think. Somebody asked, how long to wait?
He
Sit.
said that he wait till the spinal shock.
Should we wait for enough time so that the spinal shock is over and we can really prognosticate the patient?
No, sir, you can never prognosticate. That's the first thing. Please don't stick your neck out to say that we can prognosticate. Please don't try to do that. Only offer the patient surgery from the point of view of stabilization, but please do not offer them any neurological recovery. Let them say if there's a neurological recovery, it
You
is
can always give
an
a
added.
prognosis.
Well, you don't have to give a words. You'll say that the chance of recovery in my hands, as far as I look at it, don't look very good at all. Well, if the patient recovers, it's not because of me, it's despite. Yes, I will try and make him stable and make him sit up. Yes, sir.
Okay, I have seen a patient in which you cannot tell, of course, on the MRI whether the dura is injured or not. That's the unfortunate part in our MRIs. I've seen one patient having, there was a problem of partial paraplegia, and when we opened the cord, dura was punctured and bone piece opens inside that.
Correct. Get it out. Get it out. If the dura is repairable, please repair it. Yeah.
But suppose patient doesn't want surgery, say if there is no recovery, we would not like to operate it. But we operated that and we found recovery. In those cases, how we could find, if we would have not operated, patient would have gone into problem in due course of
Otherwise
time.
also you would have operated probably.
There
If
is
the
no
dura
way
is
to-
punctured. My question is dura is punctured.
Next
The
question.
dural
Sir.
puncture, you can pick it up on.
So,
The way
No, no,
to-
So you-
long
yeah.
way, long way.
If you clearly
I shall invite next question if there is any. Yes.
Can I ask?
Yes.
I'm Dr. Mahapatra from Indian Spinal University. The question is to Dr. Hegde. Most of your cases I saw the degeneration is at one level. You've done a TLIF at that level and you have done a
Flexible system.
DSS at the higher level or one level below. What is your point of contention that you do is it a protective thing you're doing, thinking that will go into adjacent segment disease, or did you evaluate the patient that the pain was coming from the higher level, from the degenerated disc, so you did a dynamic stabilization there?
Now, if
So what was your point that in all your cases where there is one single level degenerated disc disease, you're doing a TLIF at that level, index level, and a dynamic stabilization at the higher level?
no, if there is no evidence of any involvement of the higher level or lower level, I do not extend a flexible system above. If there is some evidence of degeneration, if the pain complaint of the patient is not very clear, if we feel that there are modic changes and end plate changes in the higher level, but there is not significant compression, I would protect that level. So I must be doing about 40 degenerative cases on a month-to-month basis. So out of that, probably around 5 or 6, I would extend a flexible system above or below. I tend not to do it below because the angle that I need in the lordosis of the flexible part of the rod is not able to be achieved. So it has an eccentric kind of shape at the end. So I stopped doing it at the alpha S1 level and the reverse thing. In a couple of cases it has worked, that's what I was showing, but I do not do it now on a regular basis. I think the flexible rod that needs to come in due course of time will have to be designed better than what is this available. There are 2-3 issues that I need to tell you. One, that the top the movement where it is occurring is above, just proximal to the fixation onto the screw. That is a very bulky implant, and in thin individuals can lead to localized pain. So the advantage of mobilization really does not happen. I've taken flexion extension x-rays, I've asked them to bend and all that. It takes a long time for them to get adjusted. So I think a design change, one of the things that Ram also showed is the newer design that is coming, which is smaller, would probably be better. But to answer your question, if there are no changes in the above disc or a very minimal changes, I do not extend instrumentation higher up.
If there is any changes of degeneration in the MRI, you extend your instrumentation.
That's right. If there is changes, there is a collapse of the disc height. If there is some evidence of facetal arthritis, and then there is pain that is not explained only on one level, then I would extend.
So do you do any pre-operative evaluation to?
Clinical. I have not found discogram to be very reliable, so I stopped doing it. Earlier on, I used to do discogram to prove a point, but I have not found it to be very reliable. The patients complaining of pain is depending upon their psychological makeup. Some people complain very early, even before the discogram has started happening. So I stopped doing it. And some very rare cases when I'm really not sure how many levels to extend, that's the time I still do a discogram, but that's very infrequent.
Any other questions from anybody? Dr. Sambat, there, you had a question? Yeah.
I want to know, is decompression and fixation is sufficient in lumbar canal stenosis or fusion is a must?
You're talking of a patient where you are fixing with the idea of ablating motion, you have to fuse. If you are stabilizing with the idea of preventing supraphysiological motion but allowing physiological motion, you do not fuse. Have I made a little point clear about what I'm trying to say? So where you're ablating motion, you have to fuse. Whether you do it intertransverse plus interbody or interbody alone or interbody, whichever, that's your call. But where you're stabilizing but only preventing supraphysiological loading, that's the only place where you don't fuse. Any other questions from anybody?
Contraindication of decompression in the lumbar canal stenosis.
Contraindication for decompression of lumbar canal stenosis.
Anesthesia.
So contraindication of decompression lumbar canal stenosis, first, patient having radiological stenosis but no clinical picture. We treat the patient, not the scan. There are so many patients who don't need a decompression. That's the biggest contraindication first. You'll see innumerable patients with an LCS reported on an MRI which should not be operated. They are the highest incidence of failed back. That's first. Second contraindication, those people who have medical comorbidities, as you mentioned, where they are actually wanting the surgery, they deserve the operation but cannot be operated. Those are the people where you have to modify lifestyle. You can probably use physiatric help, that is pain clinics, etc. for some time. That's the only contraindication. Otherwise,
Stress is basically we should correlate the radiological as well as the clinical.
so clinical first, radiological second.
Sometimes it is confusing.
Then go on the clinical. Treat the man and not the scan. Treat the man and not the scan.
We should give epidural and then see the pain.
No, sir. Treat the man and not the scan. That means you see if the patient is relatively asymptomatic, but the scan is dangerous looking, still go with the patient. Go with the patient. If he says, डॉक्टर साहब मैं चल सकता हूँ, डॉक्टर साहब लोग बोलते हैं ऑपरेशन करा लो, लेकिन वैसे मैं पहले 10 किलोमीटर चलता था, अभी 8 चल सकता हूँ, तो 8 चलना ठीक है सर. So that's how I look at it. हाँ वो 8 जब 8 कदम हो जाए तो ठीक है, then you have to operate.
Sir, a young patient with incomplete paraplegia post-traumatic. Patient asked the doctor, honestly, if the surgery is not going to make any difference to the neurological recovery, why should I get operated?
Correct. 2 reasons. One, because surgery is going to make your nursing care post-operatively easier unless you have adequate nursing care to look after yourself. Either you're very rich or you're so poor that everybody in your family can do your log rolling, right? That is one. Second, the chances of all secondary issues related to long-term sort of being in bed, recumbency, chest, bed sore, urinary tract. That's the only thing that you can say. But incomplete neurology, as you said, is a place where you would still err in offering surgery. Complete neurology either way, that is total shutdown or bad looking x-ray but with neurology intact, that's the place where you're not going to push for the surgery.
Incomplete injury with instability, I think you must offer surgery because secondary neuronal damage is a known entity and causes worsening of the symptoms.
Chances of recovery is there.
Yes, of course.
Thank you, sir. Thank you, the speaker, for the nice session. And we close the session here. Thank you very much.
No, that is most of the audience not that is a compression. No, I agree.
Of every orthopedic surgeon, and lot of water has flown under the bridge since Colesis has actually described this, and it's no more a simple entity of extra-articular fracture which is known as Colesis, which was Abraham Colesis in 1814 and is popularly known as lower end of radius fracture, because the complexity of the fracture is such that it has gone much beyond simple close reduction plastering technique and simple management. And now we know that there are so many classifications, so many different controversies, so many complications which arise from this improperly treated fracture. And at the same time, there is a bit of analysis which needs to be done to understand the fracture anatomy, to know the pathology, and to understand what needs to be done for it. So we have so many different ways of gauging what is the complexity of this fracture, and at the same time to know exactly the way it has to be managed. So we have today very eminent speakers in this panel, which we are going to discuss this. And we have first Dr. Sunny, who is going to discuss Colesis fracture in old people, conservative treatment. Of course, it has it has stayed this treatment, and we know that there are certain people who needs to be treated just with the conservative treatment because it remains stable and it gives excellent functional result at the end of 6 or 8 months. There have been plenty of trials which have been done, which has done a study of conservative treatment against the operative management, and we have known that in the old people it certainly has some kind of say in this treatment. So I would request Dr. Sunny to please go ahead and talk about conservative management of cholecystitis. Dr. Sunny, please.
Good afternoon, gentlemen. chairpersons, and my dear friends. I know that I am going to talk an unfashionable treatment for the present generation. My experience in orthopedics for the last 43 years has taught me that if you are too energetic, you need not be too energetic in treating a Colles fracture. Just a few words about Colles fracture. We all know that in 1814, Abraham Colles described this. He was a professor of anatomy and surgery in Royal College of Surgeons in Ireland. And I have been looking for a good definition in my whole experience, So many people have, Watson Jones have described this a lower end of radius fracture with inferior ulnar dislocation. But I think the best definition I got it from Professor Sinha, late Professor Sinha. He is described as a distal end of radius fracture at the cortico-cancellous junction. It always happens in the cortico-cancellous, this particular Colles fracture, with the fracture of the ulnar styloid process or a medial ligament injury of the wrist joint. It happens, we all know it's an outstretched hand. We don't have to have this much of all. Usually a trivial trauma in old people will cause this fracture, And we know that it gives a classical deformity. If you look from the side, it looks like a Dinofock deformity. And if you look from front, you will get a Manus valgus deformity. And we all know that there are 6 displacements which can occur: impaction, lateral displacement, lateral rotation, dorsal displacement and dorsal rotation, and supination. I have put this slide exclusively to show that I am not going to do a measure these angles, and I am not going to do any, draw any lines or make any measurements of, displacements because post-operative X-rays rarely taken, and because I am treating an old patient, I will tell you my regime and why I decided to do this treatment in old people. I usually do a manipulative reduction with or without anesthesia with IV sedation, and I try to correct all the deformities by traction and by molding the plaster, and I apply a slab to start with, and after 1 week I convert into a cast. It may need a change in another 2 weeks' time, and I'll give anti-osteoporotic treatment, and I allow early movements of the fingers, elbow, and shoulder. It got stuck. This is just to show an X-ray fracture at the cortico-cancellous junction, which has been reasonably reduced, and a well-modeled plaster has been given. And this is one of the functional results in one of the patients. So what are the factors influencing me to do the conservative treatment? Because I am talking about old people with less physical demands, and their health status is poor. Their lifestyle is housebound, and comorbidities like diabetes, hypertension, coronary artery disease, and they are also recently with a poor eye vision, poor bone quality, and this is a less costly treatment, and they are back in the home within 2 to 3 hours. This is an outpatient treatment. If you ask me, is Colles fracture over-treated nowadays? Vehemently, I will say yes. There is no confusion of treating a Smith fracture, Barton's fracture, Chauvet's fracture, but confusion exists in treating the classical Colles fracture. Any talk should be supported by, some literature evidence. If you look into the literature, I have not seen an article in the last 3 years about this conservative treatment with the obvious reasons. Eagle et al. In 2010, in an American Journal of Surgery, he compared with operative and non-operative treatment. And his conclusion is, in low-functioning patient with multiple medical comorbidities, conservative management is safer option and is likely to give acceptable clinical outcome even with a malunion. Arora et al. In Journal of Orthopedic Trauma 2009, he did a comparative study of clinical and radiological outcomes on unstable Colles fracture. And in patients older than 70 years, he did compare the operative and non-operative, that is volar locking, with a non-operative treatment. And no difference was found in the subjective and functional outcomes for surgical and non-surgical treatment in the patients with older than 70 years. Young et al. In 7 years, they had done a 7 years outcome study in Colles fracture, and they could not find any apparent advantage with the external fixation, and overall good function with non-operative treatment was good. That was their conclusion. Obviously, treatment of Colles fracture has been a debate for the recent time. I think it went into disrepute. The conservative treatment went into disrepute because it is often treated by the junior resident in the department, no proper anesthesia, basic principles of immobilization of one joint above and below is broken, and lack of proper follow-up. It is because it is not our mother or the parents who get the fracture, it is our grandparents or, who get the fracture, So my aim of treatment should to get a good function, reasonably looking wrist, and prevent complications and no pain. When I started orthopedics, the only complication was a Colles fracture. And my professor used to say, those days when I was doing postgraduate, all Colles fracture unite in malunion, which I reasonably agree to, especially we are talking about old people treated by conservativity. And there should not be any pain after your treatment. I would say that the surgery should be avoided because of following reasons: old age with comorbidities, high risk of anesthesia, chances of infection, chances of loosening your implants, and discomfort that due to the external fixation. Especially these old people who are confused, can get a lot of problems with this external fixation which is jigging out of your body. They get sleepless nights, and obviously it is costly. A close reduction and of a Colles fracture will cost you 2,000, and if you are going to do a surgery, it costs 25,000. Are we satisfying the patient, or are we satisfied ourselves by operating these patients? When we get a good functional result by a conservative treatment, why we invite complications by surgical treatment? That is my argument. Ladies and gentlemen, this close reduction and plaster treatment in fractures is an art which the new generation orthopedic surgeons are not exposed. I hope I am correct in saying this statement. This has to be cultivated. If you do not do this, you cannot, get a good result out of this. An ounce of prevention is worth a pound of cure. So, ladies and gentlemen, let us leave our grandmas and grandfathers with comfort. It is not the 100% anatomical reduction that is needed. A good, functional, painless joint is the aim of the treatment in Colles fracture. My dear youngsters, AO treatment does not mean that always operate. But the way they are going ahead, I find that whatever cases they get, if it is a fracture, displaced or undisplaced, you operate. Let us not do it. Thank you very much.
Now I invite Dr. Anup Agrawal, complications of distal radius fracture.
Good afternoon, everybody. I totally agree with Professor Sunny, what he said, that it's an art that we need to learn, the younger orthopedic need to learn, and even we need to reinvent that art to prevent the complication. And if you have not done it properly, yes, there are complications. So I'm going to tell you about these complications which can really create havoc for the patient. So well-known complications are there: malunion, compression neuropathies, wrist and hand stiffness, attrition rupture of EPL, and CRPS. I'll talk one by one. Malunion could be extra-articular, the normal cholesis fracture, or it could be intra-articular. And we need to really differentiate between intra-articular malunion and extra-articular malunion because we need to treat them separately. Why actually we need to know that all these shortening and everything, the measurement we learn in every cholesis fracture or distal radius fracture? We need to know what actually it creates, what kind of complication it creates. So we need to know the kinematics. An increase in 18 to 42% force is borne by distal hernia with relative shortening of just 2.5 millimeter, and TFCC become tighter, DRUJ is disrupted, and further increase by 6 to 8 mm shortening of ulna. It impinges on triquetrum, causing a lot of pain to the wrist. So this can be created by radial shortening. If you have an excess dorsal angulation, it causes the load distribution shift from volar radial to dorsal ulnar. And at 30 degree of dorsal angulation, there is an increased load of 50% over the ulna. So abnormality of this significant in rotation and instability of DRUJ is demonstrated at 20 to 30 degree of excess dorsal angulation. If you have an increased decreased radial inclination, it will affect the grip strength, it will affect the range of movement of radius and ulnar deviation, and will distribute the load unevenly on the wrist. So we need to correct that. So what are the acceptable parameters? I think that has already been told. So there's a beautiful study by Feurer et al. Which was published in 1981, where they have compared 64 malunions. There they have compared their functional impairment. They have laid down certain criteria, the lower limits. That was radial deviation of up to 20 to 30 degree, sagittal tilt of 10 to 20 degree, and radial shortening of up to 2 millimeter. This is what we can accept to have a good functional outcome. So goal is to get a palmar tilt in sagittal plane, radial inclination in coronal plane, rotational malalignment, restore the radial length, and restore the DRUJ congruity. So how to do that? We need to correct that. So indications are, if you have a really poor radiograph as per the parameters being told, if you have a pain at mid-carpal joint, radiocarpal joint, or DRUJ, there is a decrease of range of movement of the wrist, or there is a cosmetic deformity. Nowadays we do get the patient where patient complain of the cosmetic deformity in younger patient, especially if you have an intra-articular fractures. We need not to correct where the patient general health is bad, severe osteoporosis, or there is a post-traumatic arthritis has already been happened, or there is a significant dystrophy. When should we operate these patients? There are a lot of studies which is being that, but one of the beautiful study by Jupiter and Ring, who have worked a lot on distal radius, they have said that overall functional and radiological outcomes were equal whether you reconstruct late or early, but there are certain advantages of doing an early reconstruction. There is less soft tissue contracture. You can do it on high functional demand of patient, and patient do come back early on the work. So what kind of surgery really we do for extra-articular malunion? You can go for an open wedge osteotomy. It's a well-established procedure where you correct the length by doing a dorsal radial based osteotomy, which hinges on the ulnar, volar ulnar side, and you can put a graft, and then by lamina spread you can correct the angulations and put a plate. The other way to do is the closing wedge osteotomy, but the disadvantage is that if you're doing a closing wedge osteotomy, perhaps you are increasing the radial shortening. So you might have to do a resection of the ulnar head, or you might have to do the ulnar shortening osteotomy to preserve the DRUJ and TFCC. So it is good for older patient, not good for younger, very active and very hard working patient. So this is one of the cases where this kind of osteotomy has been done. So this was a paper which was published in Acta Orthopedics in 2010, where they have said that corrective osteotomy of the distal radius compared with the dorsal or volar approach, closing versus opening, they said there was no significant difference in final radiological outcome between the groups with the dorsal approach versus group with the volar approach, nor was there any difference between the group with a closing wedge osteotomy or with an opening wedge osteotomy. So really you have to assess case versus case that what you should go upon. For a volarly displaced malunion, you need to do a volar opening osteotomy or do a sliding osteotomy, a simple one. Then we talk about the DRUJ function. This is another very important complication. What does it cause? It causes impaction, it causes incongruity of the joint and instability, ultimately leading to pain at the wrist. The intra-articular incongruity, what are the procedures being laid down? We can do Kapanji procedure or a prosthetic replacement, or we can do a direct procedure. For extra-articular incongruity, you can go for a reorientation of sigmoid notch or do a shortening osteotomy of ulna where the ulnar variance is more than 2 mm, or if it is less than 2 mm, we can go for an Weffer osteotomy arthroscopically. Where there is an instability at DRUJ, you can go for Kapanji or prosthetic replacement. What is this Kapanji procedure? It's a well-established procedure, was described by Sof Kapanji in 1936. Where they do is DRUJ orthodesis, which treats the arthritic pain, and by removing a small part of ulna just below the neck, we create a pseudo-orthosis at ulnar neck, which causes a good amount of rotation of forearm. So you correct the pain, you correct the range of movement at the forearm. It is contraindicated in a very unstable RU joint or a joint dislocation of radioulnar. There are, yes, known complications with this. You can have a distal ulnar stability if you have done excessive resection of ulnar bone just below the neck, or you can have a painful clunk if you have more than 50, it is present in more than 50% of patients, this painful clunk with this procedure, or you can have an excessive reactive bone formation over there. Next procedure, Darrex procedure, is generally performed in an elderly patient with low functional demand. So this is a procedure which we can do in an older patient where the demand of function is really low. But yes, there are known complications of Darrex procedure, that it does not produces uniformly good results, especially in young patient. It does causes instability of distal ulnar shaft. There could be a painful subluxation of external carpi ulnaris, extensor carpi ulnaris over the transexit end of ulna. So you have to be careful over there once you are removing the head. There could be a palmar subluxation or translation of the carpi, and you can have the convergence. It's a beautiful procedure. A short procedure can be done for an older patient where you remove the ulnar head, and you have to really careful for the extensor carpi ulnaris here. Yes, there are reported ulnar head prosthesis which causes a prevent impingement and improves stability, but I would say that Kapanji is a better procedure and one of the good procedure for DRUJ dysfunction. Then you can have intra-articular malunions. So goal in intra-articular malunion correction is to restore the articular congruity, which is one of the most difficult job if you have really intra-articular malunion. So you have to be careful in selecting your patient. You have to prevent the articular cartilage and give the patient pain-free function. So indications for intra-articular malunion corrections are: once you have an intra-articular incongruity more than 2 mm in AP view, or you have intra-articular incongruity in coronal plane with subluxation of radiocarpal joint. So again I emphasize that you have to choose your patient very carefully once you are jumping on to correct the intra-articular malunions. This is a wonderful paper by Ring et al. Again. the result of corrective osteotomy for treatment of intra-articular malunions are comparable with those of osteotomy for the treatment of extra-articular malunion. Again, a word of caution that you have to do it properly and choose your patient computerly. There are certain recent advances that people are doing now, computer-assisted technique, even for the distal intra-articular fractures where there has been malunion. Then we talk about the CRPS, one of the commonest complication which happens in most of the patients of distal radius fracture. We all know type 1, type 2 symptoms. We all know there is a burning sensation, local swelling, increased sweating, change in skin temperature, color, there is a softening of the bone. Diagnosis, there are no specific tests. It's basically a clinical diagnosis. Treatment, you need to give physical and occupational therapy. Drugs, a different kind of antidepressant, steroid, NSAID can be used. You can use tactile discrimination technique. You can have local injectables, blocks. They are really useful because once the patient is pain-free, he can really go for a good physiotherapy. So, to take home message in treating these or preventing complication is that prevention is the best cure. So you need to be careful once you're going for conservative management. Yes, we all can do that. Recognize the complication early, treat them early, and case selection is very, very important on jumping on to especially surgery onto the malunions. Thank you for your being.
Thank you, Dr. Anurag. It is an excellent cautionary lecture to tell all those who operate and all those who also conservatively treat the lower end of the radius fractures, and to have our view on the internal fixation. Dr. Arindam Banerjee is going to give you insight on the internal fixation of lower end of the radius fractures, which is a huge topic to be discussed in 15 minutes. Sorry, Dr. Arindam.
Good afternoon, Mr. Chairman, sir, junior and senior colleagues. My brief today is to talk about ORIF of distal radial fractures. Now, this is a very common fracture, as we know. It comprises of 17% of all ER visits, and it has been found that it is common, this percentage is common to almost all races. There is a bimodal distribution in the age. There are peaks in the young adolescent and in the elderly, but the gender ratio is reversed. In the elderly people, the female to male ratio is 4:1, whereas in adolescents, boys is to girls is 3:1. Now, in the past, we used to be taught of these as specific fracture types. So we were taught about Colles fractures, we were taught about the reverse Colles Smith, then we had the different types of Barton fractures, then we had the radial styloid or the Schoffers fractures. But what is increasingly being understood is that these are not discrete fractures, but in fact a spectrum of diseases. So we start on one side with having fairly simple fractures, and then we have intermediate fractures and go on to have more complex fracture dislocations. Various modalities of treatments are available. We have on one side, we have things such as MUA, POP, K-wires, X-fix, combinations of K-wires and X-fix. Then there are different types of plates which are put, volar plates, dorsal plates, different designs. And then there is arthroscopically assisted fixation, and even sometimes bone grafts have to be used. But one thing which we are noticing is that the ORIF as a modality of treatment is rising. Now, this trend started initially in the USA, primarily among hand surgeons who had a lot of training and fixation. Then it spread to the general orthopedic surgeons in the USA, and then on to the Europeans, and it has also come to India. So we are fixing more and more of these fractures, whereas 10 or 15 years ago we hardly fixed any. So this is picking up. Now, is this change evidence-based? In other words, do we understand these fractures more, and that therefore we are treating them better? Have our surgical skills and training, has it improved? Have the expectations of our patients improved? or is this change in the interest of industry and the surgeon? Have our treatment goals changed? Previously, were we just happy to have a pain-free, mobile and stable wrist and accepted the deformity? Or are we trying to achieve close to anatomical reduction? Now, what should be our goal? Now, whenever we have these questions, it's best to go to literature and look for answers. Now, there are many hundreds and thousands of papers on ORIF, of the distal radial fractures. So I have just chosen 3 papers just to look at these, and this is a comparison. Now I'm not talking about conservative here, I'm only talking about unstable fractures, and this is a comparison between usage of ORIF versus use of percutaneous pin fixation plus external fixation. And this paper from Frankie Leong showed that the ORIF group gave much better results, and these results were statistically significant. Another paper from Eagle in 2008, published in the JBJS, again looked at the same group, and they found that while there was no clear advantage with either treatment, there were fewer reoperations in the ORIF group. And because of that, I think this is very important and relevant to India, because I think our patients are fairly intolerant of reoperations. So if we have to operate a second time, I think they consider it a failure. So it's important that I think this is a paper which is very relevant to us. And finally, this paper again published in the JBJS in 2009, which looked at the functional outcomes of unstable distal radial fractures treated with open reduction versus percutaneous fixation. And here again, there was not a lot of difference in the long run, but what it did show was that ORIF was superior for patients who required a faster return to function after injury. So I think this is also very important, because someone like us, if we have a fracture of a wrist, we cannot stay off work. We would like to get back to work as quickly as possible, and therefore we need to have a modality. Maybe in the long run, conservative and operative might give similar results, but we would want to get back to our work as soon as possible. So therefore, this option comes in. Now, if we are to do an ORIF, we have to restore anatomy. And what is important is in anatomy is to understand what is normal, and only when we know what is normal can we try to restore it. So these are basically lines drawn on X-rays, and you can see these lines. These are the palmar tilt, the radial tilt, the radial length and ulnar variance, and articular congruity. These are the things we have to improve. And what is the rationale for this? Well, the palmar tilt, it has been found that if there is more than a 20-degree loss in palmar tilt, there is a significant loss of function. Similarly, with the radial length and ulnar variance, more than a 2 millimeter change results in symptomatic loss of strength and pain. Radial inclination, if we do not restore it, it increases the load on the triangular fibrocartilage, which leads to decreased grip strength. Carpal malalignment is very important to restore, because if we don't do that, then we will have a poor hand function, and we will have secondary ligamentous injury and consequent arthritis as well. And finally, this goes without saying, intra-articular incongruity. If we cannot, it is not possible to accept more than 2 millimeter step off, because if we accept that, then again we will have a symptomatic radiocarpal arthritis. Now, there are many classifications on how to look at these fractures. Now, I have just chosen one, which is the one which we almost always use for different types of fractures, which is the AO classification. And this is relatively simple. We are all familiar with it. There's a type A, type B and type C. Type A is extra-articular, type B partial articular, type C complete articular. And again, the A fractures are divided into A1, A2, A3, B1, B2, B3, C1, C2, C3, and this, so it gradually increases in complexity from A1 to C3. Now, there is another very important concept which we need to think of, and that is, this was published by Rickley in 1996, where he talked about the 3-column structure of the wrist joint. And here there is a radial column, there is a ulnar column, and in between the two is an intermediate column. And these columns are very important regarding load transmission. And unless these columns are put back together, then the load across these joints actually changes. And I think this is why perhaps more and more fractures are being fixed, because if you look at this, you would maybe have to fix a lot more fractures than what we normally do. Now, this is the common algorithm which is accepted nowadays. You have on one side, you have the non-displaced fractures, and it goes all the way up to completely displaced unstable fractures. So it's not necessary to do an ORIF in every case. It's important that for instance, if a patient has a non-displaced fracture or a minimally displaced fracture, a reducible fracture, they can be treated with simple modalities of treatment, such as a cast, a splint, close reduction, and percutaneous wiring, etc., all the way across the spectrum into the more complex group, which require ORIF and perhaps a combination of treatments. So now we are just going to talk about ORIF. Now I'm not going to talk about CRIF, which is close reduction internal fixation, just ORIF. The indications are complex, comminuted intra-articular fractures, volar shear fractures, fractures which have a metaphyseal and diaphyseal extension, and fractures which disrupt the distal radio-ulnar joint. Now the approach, there is the classical Henry approach and there is the extended carpal tunnel approach. I personally prefer the Henry approach because it is direct, takes you onto the fracture, though sometimes I put the incision slightly more ulnarwards. If one has to do this, it is very important to do a meticulous dissection, because it's very easy to damage the radial artery while doing this. And one of the precautions we should do is that we should never use a S mark. When we put our tunicate, we should just elevate and then put the tunicate. Otherwise, if you put a S mark, the radial artery will really shrink and you will injure it without realizing it. And then there is a dorsal approach. Now again, I would like to say that I totally agree with Dr. Sadi that most of these fractures do not actually need ORIF. I would say that they should be only done once in a while, but if one is doing it, then this dorsal approach is usually done between the tendon, the different tendons, and the fracture is approached directly and fixed. This is what it looks like over here. Now, whichever approach we do, it's important to do a meticulous dissection of the fragments using small forceps. We need to put the geometry together, take the little pieces, put them together, and then we need to fix it. And the principles are that first the lunate fossa should be reduced, the radial column needs to come together, and then we can put our volar or the dorsal plate. Now there's a lot of different types of hardware available. There are the buttress plates, there are the straight plates, there are the fixed angle plates, the variable angle plates, then there are fragment specific plates. We should have them in our armamentorium. It's not that we should do them for every case, but we should know at least what is available and use them for every appropriate case, because as we know, this is a spectrum and we need to analyze the fracture. Sometimes we even need to do a CT to look at them, look at the different fragments, and then we have to decide how to fix them. So I'll briefly run through a few cases. 57-year-old lady who had this fracture, had a CT scan and required fixation dorsal plates were put. Now it's very important that we realize that when we are putting plates on the dorsal side, there is a lot of irritation there could be a lot of irritation to extensor tendons, and there is a risk of secondary tendon rupture because of tendon fraying, and because of that they should only be done in cases where they're absolutely necessary, and they should be done with a very low profile plate. So we should not put a thick plate. Another one, a dorsal fracture treated with a fixed angle plate. Both the columns in the radius have been reduced. Here in this case, a volar plating has been done for a dorsal and volar fracture. Now the advantage is that there is less tendon irritation, but the reduction can be difficult at times because it may be difficult to catch hold of the dorsal fragment with the volar plate, but it's possible and it is better tolerated than external fixation. Then there are fragment specific fractures. Over here you can see the radial styloid has been fixed with a fragment, and the one on the dorsal side. Dual column plating here for this kind of fracture. Over here you can see this, how it's been fixed. Now more fractures, a A3 type of fracture which has been fixed with a plate, and the anatomy has been restored. Another A3 fracture which has been fixed with the appropriate plate. A B3 fracture which has been suitably fixed. C2 fractures which have been fixed. C3 fracture which also it was possible to bring it together and restore anatomy. Now this is a more complex case. This is an elderly lady. She was actually very elderly.
Kindly finish, sir.
Yes, I've almost finished. So this is a patient who required fixation with this modality. Initially fixed, put with a cast. It was not suitable. Then she had a K-wire put in, a plate, and then X-fix was also used to bring it together. Eventually the X-fix was taken off quickly and the ORIF was left in, and she had a very good result, return to function. So yes, the number of ORIF is rising, and the proof of the pudding is in the eating. In Finland, which is a country which is insurance neutral, they have had a 13-fold rise in ORIF between 1998 and 2008. So there are no commercial interests in their fracture fixations because they don't have it's all done under the public sector. So to summarize, it's important to know the anatomy of the wrist. The 3-column fracture concept is important. Combination techniques may be required. Complex injuries may require multiple incisions, and anatomical restoration of length angulation is of importance to prognosis. However, let us not get carried away. The patient needs to be assessed in totality. A patient is not equivalent to just a series of x-rays. We need to think of other things. Which hand is dominating? What is the soft tissue injury? Is there an open injury? What is the occupation of the patient? And only then should we take a proper decision. Thank you very much.
Can I call upon the panelists to be sitting here, please? And I would invite questions for very important discussion that we'll have on this, because very interesting topics. We've discussed the conservative management, the operative management, and the complications. Yes, doctor. Can you identify yourself? And
I am Dr. Pankaj Sharma from Kanpur.
yes.
Sir, we keep lamenting that the conservative art of conservative treatment is going. From a senior person like Dr. Sunny, I would like to know his protocol for a 75-year-old lady. He walks into a OPD with a Codi's fracture. Does he give fracture hematoma? Does he give use sedation or GA?
Yeah.
How to do it? When to take an X-ray again? A brief.
Actually, he had given a slide in which he said that he does it under IV sedation. He reduces the fracture, he gives a slab, keeps it for a week, then changes into a cast, mobilizes early, starts his shoulder and elbow mobilization, and painkiller if need be, and he removes the plaster in about 6 to 8 weeks. So I think that was clear. The clarity of this slide was showing how he treats, and I think that's a good way of managing conservatively. So I don't think there is anything which has changed over last 40 to 45 years in that. Dr. Sunny, if you want to add, sorry, yes. Ek mic dena unko.
Yeah, I don't, the simple technique, I do it immediately in the outpatient. Usually, if a minor displacement, I don't give even a sedation. If it is a more displacement, if you think it's painful, I will give IV sedation. No anesthesia. If you go for anesthetist, you are in trouble. So that is why, So you do this, and in the minor OT, give a, patient is supine, 90-degree flexion of the elbow joint. One assistant gives a, traction along the thumb, which will look after this impaction and upward displacement, and that is maintained for half a minute, and then I do start putting the plus slab, and while putting the slab, I will correct the dorsal displacement and the radial displacement, and then give a slab. No, I don't include the elbow.
And one thing important he said was to reduce the cost, he doesn't even take an X-ray.
No, normally I don't take any post-operative.
So it saves tension of patients and him, so that there is no post-operative evaluation of this. So functionally, what is he needs?
Do you feel if you take an X-ray after 10 days and then
it will definitely go displacement. There will be when I change the plaster, then I can whatever it is, But I accept, that all fractures in 75 years maliminites. I am not claiming that I am going to get anatomical, I accept it. But the function is good and least inconvenience to the patient.
See, basically what he has been discussing is an extra articular fracture of the radius, which is not a complex fracture, which will not have any DRUHA problems and probably may or may not have an ulnar styloid fracture. So we are talking about simple cholesis as it was described when there were no X-rays at the time of Abraham cholesis, right? But then here the things have changed tremendously in last 20 years because the complexity of the fracture is much more. The distal radial joint importance is evaluated. We really did not know about the triangular fibrocartilage. So that is what is a new thing.
I personally think that we don't have